Welcome, learners, to another deep dive. Today, we're cutting through the noise to get to the core of a critical topic in fetal medicine, Pierre Robin sequence.
Exactly. We've compiled a comprehensive stack of sources for you, including recent research from the American Journal of Medical Genetics, a key paper on prenatal diagnosis, and a systematic review focusing on genetic mutations. Our mission for this deep dive is really to distill the essential antenatal focused insights into Pierre Robin sequence, giving you the vital knowledge you need.
Right. We'll be focusing on its prevalence, the fascinating array of associated anomalies, the underlying genetic puzzle, and particularly the nuances of prenatal diagnosis for this complex condition.
Okay.
Let's unpack this.
So first, let's maybe establish a clear definition. Pierre Robin sequence, or PRS, it's fundamentally characterized by a triad of features. Micrognathia, that's an abnormally small lower jaw.
Okay.
Then glossoptosis, which is the backward displacement of the tongue. And crucially, a resulting airway obstruction. Now, a cleft palate, a gap in the roof of the mouth, is also frequently associated. It occurs in about 90% of patients. Though it's not always considered a defining feature of the sequence itself in, let's say, every single definition.
So it's that combination of a small jaw and a displaced tongue that creates the potential for significant breathing issues right from birth. That makes perfect sense. And what about its occurrence? How common is PRS, and what does the latest data tell us about variations?
Well, the prevalence of PRS is reported to vary quite significantly across different studies. You see, it ranges from 1 in 8,500 to 1 in 20,000 live births.
Wow, that's a big range.
It is. Our source from Stoll et al., which looked at a well-studied French population registry over 28 years, it reported a prevalence of 2.29 per 10,000 births. And what's truly insightful here isn't just the number itself, but understanding why these ranges exist.
Right.
It really highlights that variations in diagnostic criteria and study methodology directly impact how often we think we see PRS. It definitely pushes us towards more standardized approaches for better data comparability.
Given how significant those potential airway issues are, why is early diagnosis so crucial, particularly prenatally, for this condition?
Prenatal diagnosis is absolutely paramount, precisely because of those potential life-threatening respiratory problems immediately after birth.
Makes sense.
Early detection allows for critical multidisciplinary coordination. You can get the teams together, initiate selective treatment steps. This preparation can drastically cut down the risk of severe neonatal hypoxia, that's, a lack of oxygen getting to the brain, or the need for emergency interventions like a tracheostomy.
Which you really want to avoid if possible.
Exactly. Ultimately, it helps both parents and practitioners to be fully prepared before delivery. It makes a world of difference for these newborns.
That makes perfect sense for immediate care. But here's where it gets really interesting, isn't it? Pierre Robin sequence often isn't an isolated finding. What does the research highlight about associated anomalies, beyond that core triad?
Indeed, that's a key point. A significant proportion of PRS cases co-occur with other congenital anomalies. The Stoll study, for instance, found that a high 69.7% of PRS cases had associated non-PRS anomalies.
Wow, nearly 70%.
Exactly. This high prevalence strongly justifies a thorough screening for other congenital anomalies in any case presenting with PRS. It's rarely just about the jaw and tongue.
So with such a diverse landscape of potential issues, it's clear we're not just dealing with one isolated problem. This complexity naturally leads us to ask, what types of associated conditions are we typically looking at? And what systems are most commonly affected?
Right. The associated anomalies fall into several key categories. First, we have chromosomal abnormalities. These were present in about 11.2% of cases in the Stoll study.
Yep.
This included, for example, 3 cases of 22q11.2 deletion syndrome. That's a specific missing piece of chromosome 22, along with others like Turner syndrome, various autosomal deletions, and unbalanced translocations. And actually, the 22q11.2 deletion is frequently cited as the most common chromosomal abnormality found with PRS in the broader literature.
Interesting. What else?
Next, there are non-chromosomal recognizable conditions, or what we call syndromic PRS.
So PRS is part of a bigger picture.
Exactly. PRS occurring as part of a recognized genetic syndrome. This accounted for a substantial 30.3% of cases. Common examples from the Stoll study included Stickler syndrome and Treacher-Collins syndrome, which often impact connective tissue or facial development.
Okay, giving you a sense of the broader patterns.
Precisely. And while dozens of other rarer syndromes were also noted, the OMMIMDAE database online Mendelian inheritance in man lists 34 conditions associated with PRS, and 18 of those have a known molecular basis now.
Okay. In the last category.
Finally, multiple congenital anomalies, or MCA. These were present in 28.1% of cases in the stool study. And what's striking here is that the most frequently affected organ systems in these MCA cases were the ear, face, and neck, followed by cardiovascular anomalies and then musculoskeletal.
Cardiovascular-like.
For instance, common heart defects included VSD, ventricular septal defect, a hole between the bottom chambers, ASD, atrial septal defect, a hole between the top chambers, and coarctation of the aorta, or CoA, which is a narrowing of the main artery. This really paints a picture of systemic involvement, doesn't it, rather than just isolated jaw issues.
It really does. That's a wide range. So, given these patterns, are there specific anomalies that are significantly more likely to occur with PRS compared to the general population?
Yes, absolutely. Children with PRS have a significantly higher incidence of certain anomalies. Our source indicates that PRS increased the risk of, for example, ventricular septal defect, limb deficiency, hypospadias.
That's the urethral defect.
Yes, also hydrocephaly, which is fluid on the brain, and intestinal malrotation. And the figures are quite stark. For some anomalies, the risk can be dozens of times higher compared to the general population.
Wow.
It dramatically underscores the importance of comprehensive screening in any diagnosed case of PRS.
Given this wide array of associated conditions, it naturally leads us to ask, what's happening at the genetic level? What did your review of the literature on genetic mutations in PRS reveal?
Yeah, the genetics are fascinating. A systematic review highlighted that genetic mutations are identified in a notable proportion of PRS cases, specifically in about 30.9% of the cases analyzed across multiple studies. And it's important to note, while 56% of reported PRS cases were syndromic, and 22% were categorized as PRS plus, meaning PRS with other malformations, genetics were implicated across this whole spectrum, which really underscores their broad role.
Is there a particular gene that appears most frequently, or maybe one that's considered central to PRS?
Absolutely. SOX9. It was found to be the most common gene associated with both non-syndromic and syndromic PRS.
And what does SOX9 do?
It's a gene critical for cartilage development, and its role here is quite nuanced, actually. Here's the fascinating part. The location of the genetic disruption matters hugely. Well, for example, a complete loss of function or haploinsufficiency of SOX9. Basically, when you only have one working copy and that's not enough, that can lead to lethal skeletal malformations and severe syndromic PRS.
Really severe outcomes.
Right. In contrast, disruptions further upstream or downstream of SOX9 itself, often involving these highly conserved, non-coding regulatory elements. Those tend to cause milder abnormalities in what we call non-syndromic PRS.
So it's like the difference between a major engine failure and a glitch in the wiring somewhere else.
That's a good analogy, yes. Both are issues, but the impact is very different depending on where the disruption occurs relative to the core gene function.
So the location matters for severity and presentation. Are there other notable genes or types of mutations we should be aware of beyond SOX9?
Yes. For isolated PRS, other genes like KCNJ2, BMPR1B, and several collagen genes like KEL11A1, A2, and COL2A1 have been implicated. Mutations on chromosome 2 also show an association. For syndromic PRS, the genetic mutations are generally specific to the associated syndrome. For instance, RBM10 for TARP syndrome or TGDS for Catalmanska syndrome. The types of mutations are also diverse. Deletions, where a piece of genetic material is missing, seem to be the most common, followed by translocations, duplications, and single nucleotide changes.
That offers valuable insight into the underlying mechanisms. What about familial patterns? Do we see inheritance in these cases?
We do. Familial inheritance patterns have been assessed in many studies. They revealed maternal inheritance in some cases of non-syndromic PRS, Stickler syndrome, and TARP syndrome. Biparental inheritance has been observed in conditions like Catalmanska syndrome. This really highlights the importance of taking a thorough family history, doing that pedigree analysis when evaluating PRS cases. It provides crucial context, especially for prenatal counseling and understanding recurrence risk.
Speaking of prenatal evaluation, knowing how complex PRS can be, how effective is current antenatal screening for identifying it? And are there any objective tools available to help, rather than just, eyeballing it?
That's a great question. Traditional prenatal ultrasound screening for micrognathia often relies on subjective assessment of the fetal facial profile. And historically, this has yielded kind of unsatisfying sensitivity. It can be hard to be consistent.
Easy to miss, perhaps.
Potentially, yes. Or hard to quantify. However, objective methods have indeed been proposed. Our source from Cruz et al. Presents a promising index for the prenatal diagnosis of micrognathia, which, as we know, is a core component of PRS.
Tell us about this breakthrough. How exactly does this index work? What's it measuring?
So this index objectively assesses mandibular length. It does this by precisely measuring the fetal lower jaw length, or LJL, and then it relates that specific measurement to either the gestational age or the femur length.
Ah, so it creates a ratio or a comparison.
Exactly, it takes the guesswork out. When using gestational age, the index showed a high sensitivity around 93.75% at a specificity of 95%. It accurately identified micrognathia when those LJL values fell outside the expected range for that age.
And that was more sensitive than comparing to femur length.
Yes, it proved to be slightly more sensitive when measured against gestational age compared to femur length in their study. But the real takeaway here isn't just a complex formula, it's the breakthrough it represents. Moving from subjective impressions during an ultrasound to objective, measurable data.
Which means fewer misdiagnoses, potentially.
Fewer misdiagnoses and earlier, more confident identification, which can be a game changer for these families and the planning involved.
That does sound like a significant advancement for early detection. When is the optimal time for this prenatal assessment? And what happens if a suspicious finding is noted using this index?
Typically, these measurements are scheduled between weeks 19 and 29 of gestation. This time frame is advantageous because facial malformations might first become visible then, and individual growth differences are still relatively small, making deviations potentially more apparent. If the index indicates a conspicuous value, clearly signaling micrognathia, it should immediately prompt the ultrasonographer to look closer.
For what specifically?
To check for signs of a cleft palate in the mid-sagittal view, and to carefully evaluate for glossoptosis or any other syndromic signs that might co-occur. It triggers a more detailed look. However, and this is a critical point, while this index is highly sensitive and specific in detecting the micrognathia itself, it does not provide valid information on the precise severity of the newborn's respiratory impairment after birth.
Ah, okay. So it flags the problem, but not necessarily how bad the breathing issues will be.
Exactly. Postnatal outcomes can vary quite widely, even with similar index values. This is partly because other undetected anomalies, things like laryngomalacia, cysts, stenosis, or even underlying neurological diseases, can also contribute to unforeseen respiratory issues. They complicate the clinical picture postnatally.
So a prenatal diagnosis of micrognathia using this index is a crucial warning sign. But the full picture of postnatal respiratory needs might not be entirely clear until after the baby is born. What does this mean for immediate management and planning?
Precisely. The objective prenatal finding of micrognathia, especially when confirmed by an index like this, allows prospective parents and the medical team to take necessary measures early. This includes preparing for those potential life-threatening suffocation attacks due to the tongue obstructing the airway immediately after birth.
Being ready for the worst-case scenario.
Being ready. If a measured mandibular length falls outside that prediction interval, follow-up examinations are strongly recommended. That means looking for any additional developmental abnormalities, considering karyotyping the genetic test, looking at chromosomes.
Right.
This comprehensive, proactive approach ensures preparedness and, ultimately, can lead to significantly improved outcomes for these vulnerable newborns.
Okay, so to bring this deep dive together, we've seen how Pierre-Robin sequence, defined by that triad of micrognathia, glossoptosis, and airway obstruction. It often co-occurs with a really wide array of other anomalies, from specific chromosomal issues like the 22q11.2 deletion to numerous multisystemic conditions affecting the heart, face, musculoskeletal system, and more.
Exactly. We've explored the significant genetic associations with SOX9 frequently as a center, highlighting that the location and type of genetic mutation can profoundly influence presentation and severity, from severe syndromic forms to milder isolated cases. And crucially, we've detailed how objective prenatal ultrasound measurements, particularly using something like the mandibular length index, can offer earlier, more reliable detection of micrognathia, despite that ongoing challenge of precisely predicting the postnatal respiratory severity.
Understanding these antenatal nuances is just absolutely vital for any medical professional involved in fetal medicine. It enables you to guide families and prepare for the best possible management. And that high prevalence of associated anomalies truly underlines the necessity of a thorough, multidisciplinary approach for every single case of Pierre sequence. You can't just focus on the jaw.
Absolutely. This deep dive really reinforces that a comprehensive antenatal evaluation of PRS isn't just about confirming the triad. It's about proactively identifying the full spectrum of potential co-occurring conditions and preparing for those critical steps necessary at birth and beyond.
So here's something to think about. In this era of advancing prenatal diagnostics, with tools like objective indices and increasingly detailed genetic insights, how might the integration of these elements further transform our early intervention strategies for complex fetal anomalies like Pierre sequence? Something to mull over as you continue your own deep dives.